All right, welcome everybody. I will give everyone a few minutes to join before we get into updates and introductions and all the fun stuff, as well as an amazing and incredible panel that I'm really excited about today. So for anybody joining, welcome. We are so glad to have you. Today we are doing a lunch and learn with some amazing individuals focused on anxiety, OCD as you know it, and the comorbidity of autism spectrum disorder, also known as ASD, and we will probably use that acronym throughout. So many of you know what OCD acronym is. I don't need to go through that. But when we talk about OCD, we're often also talking about anxiety disorders. There's obviously a lot of overlap there. And then when we say ASD today, we're talking about autism spectrum disorders. And so we will spend a lot of time getting to know more about how treatment looks different, how you can appropriately treat individuals with these comorbid diagnoses, and things to make sure that you keep in mind, both as a clinician and as a supporter, somebody, if you support somebody who's walking in their shoes with this diagnosis. So if you're a family member, a loved one, et cetera, how can you offer appropriate support for them? So we will jump in just a second, but until we do, I would like everybody to say hi and introduce yourself. So when you look to the right-hand section of your screen, you'll see a comments pane. I would encourage you to please put who you are, let us know where you're joining from today so that we can say hi. And this is where throughout today's talk, you'll be putting questions. So questions that you have, comments that you have, content that you really want to make sure we talk about or address, it should go right there. And so make sure that you're using that pane throughout the talk today so that we can get to your questions and make sure we're covering things that would be important to you. So let's go ahead and get started in just a second. So again, please say hi. Please let us know where you're coming from. All righty. So we are going to start with some general introductions and information. So as always, a couple announcements. This is not a suicide or crisis hotline. If you are feeling suicidal, if you're feeling unsafe, we want you to take the steps that you need to take to keep yourself safe. It is not through IOCDF or any of our live streams. We're unfortunately not equipped to handle crisis and emergencies, but there's places that are. And so what we want you to do if you're feeling unsafe or suicidal is call 911, go to your local emergency room, or call the National Suicide Prevention Line at 1-800-273-8255. Again, I want to reemphasize that depending on where you live, this differs. So if you don't live in the US, you wouldn't call our 1-800 line, but there should be some different local emergency services that you would go through. So make sure you know who to talk to so that you can get the help that you need if you're in crisis. This live stream is also not intended to replace therapy. So while today we do have two people, myself and Rebecca, who will give a professional perspective, and Max, who will be giving a personal perspective, this is really our own stories, our own background, but then also some of our professional opinions meant to use broadly, but not specifically. And so what we mean by that is that if you're struggling individually, it's really critical that you have your own clinician and that you're working with your own provider to come up with your individualized treatment plan. The things we say, we try our best to generalize them, but generalized knowledge isn't always applicable to each of us on an individual level. So it's important that you're getting individual care as needed as well. So those are some of the main things that I always want to make sure we cover. A couple of updates. The 1 million Steps for OCD Walk is coming up. It is September 18th, so just a couple days. So make sure you find the walk near you and register. You can go to iocdf.org/walk. This is where we can come together, and it's an opportunity to join with the OCD community to walk, spread awareness, and support one another. Registration is also open for the online OCD conference taking place this year, October 8th through the 10th. You can go to onlineocdconference.org for more information. Both Rebecca and Max were just talking about a talk that they're going to be giving at the conference that they're working on putting together the content for. And so a lot of us that attend this conference, it's an amazing, amazing place, and it's an amazing 3 days to get to be with people just like you and to get to learn and feel supported by such an incredible OCD community. So I strongly recommend and encourage you to attend the IOCDF conference. This year it'll be virtual, but we're hoping that next year we'll be able to be back in person together, and it'll be in Denver, Colorado. So the conference is a place that's near and dear to my heart, and I believe that anyone else who's attended has found great value in it as well. So make sure you check that out. As always, please remember, you can go to iocdf.org/peace of mind. This is the virtual community. So these talks that we do, everything is housed in this one website. So you go to iocdf.org/peace of mind. That's where you would have found out about this talk today. It's where you'd find out about the Just Ethans or the town halls. It's also where you can submit questions and where we would encourage you to submit content that you want to make sure we cover, right? Today, we are so excited about our topic, and we hope that it brings a lot of support and education to those who need it. We want to make sure if there's other topics that would be helpful for you to hear from us on, that we're covering those. So please make sure you engage with the community and let us know so that we can be helping everybody in the best possible way. So now on to the fun stuff. I am going to introduce our two amazing panelists, and we are going to hop in. As I said earlier, today's focus is on autism spectrum disorder and OCD. And so we really want to just dive in, get questions answered, and be able to talk as a community of how we can best support this population. So first, I'm going to introduce Rebecca Sachs. Rebecca is a licensed psychologist and an expert in the top recommended treatments for anxiety, autism, and OCD. She believes in empowering individuals and their families with knowledge and skills they can use to not only manage current challenges, but to also be ready to handle new problems when they arise. Dr. Sachs brings warmth, sensitivity, and a strong sense of humor to her work. She's board certified in behavioral and cognitive psychology, and she's a sought-after clinician and speaker, regularly presenting at conferences such as ABCT, ADAA, and IOCDF, which will be coming up in just a month or so. She has a private practice in New York City and virtually in the state of New York, and is the co-director of Successful School Transitions, which is a comprehensive program for school refusal. In addition to these roles, Dr. Sachs is a single mother to an energetic and determined preschooler. Thank you so much for joining us, Dr. Sachs. Welcome to today's live stream. Tell us a little bit about why you're here and what you hope to be able to share as far as some knowledge and information today.
My pleasure. So why I'm here is I love IOCDF. I love talking with Max. This is now, I think, our second or third time together. And I love autistic individuals, and I love working with people with OCD. And this is probably my preferred interest if we're talking about preferred interest. So I could sit here and talk for more than an hour. I could probably talk for like 5 days on this topic. Yes, so that's why I'm here. And then you had a second question for me? I forgot.
Yeah, just tell us a little bit. I would love to hear a little bit about what IOCDF means to you and why you are like interested in being a part of these live streams. So what are you hoping that the audience gets out of today?
Yeah, that's great. So while I think I've sort of found some of the special sauce that works in therapy for autistic individuals who also happen to have OCD, I know a lot of other therapists out there who are in the OCD world or in the autism world often feel less confident in treating when patients who have these co-occurring conditions walk into their office. So I would just like to sort of spread as much information and really share this message that this is something that I think most clinicians can do as long as they just have a little bit more information about the two conditions, sort of understand the modifications. And I think also, like, if it's an OCD clinician, really sort of diving into the autism community and getting to know people like Max and having friends like Max, because I think it really sort of empowers you as a therapist to be able to work with autistic individuals. So I'm excited. Yeah.
Absolutely. Well, we're excited to have you here. And I love that you are able to just share this energy. It sounds like you not only love this population, but you also have kind of figured out like what works best to appropriately treat this population, right?
Sure.
And that's the most important piece. Is it's awesome for us to hear about our energy, but I know the audience is going to want to hear what works and how do we best treat the population. So it looks like Max, we might have lost her for a second due to internet. So hopefully Max will be back before you know it. But while we're waiting, why don't we jump in a little bit? And so I think it would be great, Rebecca, for you to really share with the audience the diagnostic criteria of ASD and what let's start there, and then I have a lot of other questions. We
Sure.
aren't going to jump as much into diagnostic for OCD because we talk about that a lot. And so I'll
Yeah.
just remind everyone, right? Obsessive compulsive disorder, unwanted intrusive thoughts, followed by repetitive behaviors or actions that take up a significant amount of time and cause distress in the individual's life. It's really important to remember OCD, the obsessions are unwanted intrusive thoughts. The rituals are behaviors that the person engages in that also does not bring pleasure or activity. So if you don't mind, Dr. Sachs, and then Max, we'll jump into introducing you, but if you don't mind kind of first sharing diagnostic criteria for ASD and what it looks like.
Sure. And I actually, if you don't mind, before I introduce diagnostic criteria, I'm going to add sort of an asterisk to this, because I think one of the important things when we have a patient who comes into our office who is autistic and we're treating OCD, one of the things that we want to think about is, am I treating OCD and what we would say autism spectrum disorder, that part of the core challenges of autism are also negatively impacting the person? Or do we want to more think about this as autism spectrum condition, that it's just a thinking difference in some of our patients? And what we're doing is we're not really treating the autism for some of our patients. We're just understanding it a bit more, but we are understanding the autism to then modify how we're treating our OCD. And it's going to depend on the patient. Sometimes the core challenges of autism are affecting, I would say, the mental health of an individual, and we may want to rely on our CBT skills that way. But often that's not the case, and it's just sort of a thinking difference that's going to impact how does OCD play out, how does OCD look, and how will OCD be treated. So given sort of that asterisk of like clinicians are going to ask themselves, that is what I would say is a couple really important things about autism. It's a lifelong condition. So while sort of the core thinking differences or the core challenges of autism are going to look different at different life stages, what we know is that this is a neurodevelopmental lifelong condition. So that's one thing. If we go for the DSM-5 breaks it up into two things. And what I would say is sort of more rigid or restrictive thinking and behaving that also will include sensory sensitivities. And then what we would say is social communication difficulties and challenges. What I really like to think as a therapist when I'm starting to say is this person autistic? And how is that going to affect how I'm going to interact with this patient? I really think about sort of 4 core ways that they may process information a little differently than me or than like a neurotypical individual. So the first difference may be sensory motor differences, so that people may either seek out more sensory information or may feel overwhelmed by sensory information, or a combination of both, that we may see motorically that that they move a little differently in the world. Sometimes we talk about like awkward gait as a younger child, but not necessarily awkward. Just their bodies are going to move a little differently. So that's one sort of difference that's going to impact us, because especially if someone's sensory overwhelmed or if someone's sensory seeking and those needs aren't met, then what we're going to have is a dysregulated individual. And we know OCD likes to capitalize on dysregulation. The other thing is sometimes sensory seeking or responding to being sensory overwhelmed can sometimes look like OCD, but it's not OCD. So you sort of have to figure out what's the function of a behavior. The second diagnostic sort of difference that I would say is social thinking differences. So what that may mean is that it might sometimes be more challenging to spontaneously respond in social situations, that there may be a bit more confusion about making sense or picking up on certain cues, nonverbal cues or verbal cues that seem more obvious to neurotypical individuals, or how to make sense of it or how to respond, that they may respond differently to those things. We often talk about that a lot of autistic individuals, though, do something called social camouflage or social masking, that they exert a lot of energy and a lot of time in trying to almost like break down very logically these social communication differences. So they almost have like a handbook or a file cabinet in their minds that they've spent so much time and energy doing, and then act on it. So sometimes we may have a patient that presents, socially typical, but if we dig a little deeper and we find out how much effort, or if we find out from the history how much time has been spent in sort of breaking it down in that way, that can often say, it's like, again, this person may be autistic. The third sort of thinking difference, I would say, is emotional differences. So sometimes it's hard for a person to label their emotional experience. It's called alexithymia. The second thing maybe is that they experience emotions itself a little differently. I like to say is maybe I experience emotions like a dimmer switch. I can turn my light really bright, and there's all these different gradations. A lot of the people I work with experience emotion more like a three-way light bulb: off, on, really on. And it feels like there aren't those gradations that are going on. And then the other sort of emotional regulation differences, we've seen from a lot of research that often autistic individuals experience like hyper arousal. That if we look at there's been some really interesting like heart rate research and cortisol research that just a baseline, again, maybe people are not on a 2 when they wake up in the morning, but more a 5 on from 1 to 10. And then the last difference is a thinking difference, that again, and these are all sort of generalities, but tend to be more concrete, tend to be more black and white thinkers, tend to be maybe sometimes focus more on details. And so seeing a big picture sometimes, or like abstract concepts, can be a little hard. So also thinking about how we use language in therapy, if we're using a lot of metaphors in therapy or a lot of sarcasm in therapy, and we're seeing that or we're beating around the bush, which is an expression actually, but we're doing a lot of that, and we get these sort of blank looks or confusion or misinterpretations from our patients. That's another way that we can start to think, maybe this person doesn't just have OCD, maybe they're also autistic. So I said a lot.
I'm taking good notes so that we can try to kind of cover the some of the differences you talked about. So the 4 core differences you really mentioned, Dr. Sachs, are sensory motor, social thinking, emotional experience, and thinking differences. And so
Yes.
I'm sure Max will share some personal experience in these different categories and what it's like to experience some difficulties in those areas while also having OCD. So we will hop into that now, or at least in a little bit. So first, I want to stop a second to introduce Max. So Max Wilson is a college student in St. Louis, Missouri. Max was diagnosed with OCD at age 8 and was diagnosed with autism at age 11 and again at 18. Max has spoken at multiple IOCDF conferences about, among other topics, being a young adult with OCD, the intersection of LGBTQIA+ identities and OCD, and managing OCD with other diagnoses. Max has also worked with autistic kids in their community, emphasizing acceptance and debunking common autism myths. When they're not presenting on panels or doing schoolwork, Max enjoys baking sweet treats, watching Netflix, reading, and taking pictures of their dogs. So thank you so much for joining, Max. We are so excited to have you here today. If you want to just introduce yourself and talk a little bit about whatever you want, but around some of kind of your goals for today and what would be important to make sure we cover as we're talking about ASD and OCD.
Sure. Thank you for having me. I am super excited for this. So why I'm here, I guess, well, I didn't have anything else to do right now. And B, I am really, I guess you could tell from my bio, I really like talking about autism. I feel like a lot of the conversation around autism and autistic people is centered or led by neurotypical people. And I'm not one to be great at metaphors, but one thing I read on Twitter actually was pretty good is it's like learning how to swim from a swimming instructor who's never been in the water. And so obviously some psychologists know a lot about autism, but I really think to get to the primary source, you need to talk to autistic people. I had some, sorry, regroup. I was diagnosed with autism at 11 and again at 18. And sort of the things that led to my diagnosis at 11 where I wasn't behaving like my peers were. I didn't have the same interests. I wasn't on the same developmental track. I had a lot of anxiety, and I had a lot of very passionate interests, and I didn't make eye contact and didn't like to be touched. So I pretty much everything Dr. Sachs mentioned, I was fitting all the categories. And yet my diagnosis came as a surprise to a lot of people in my family because, I mean, my family was great, but they didn't know. This was in 2010. And even though it was only 11 years ago, a lot has changed around public understanding of autism since then. And people were confused, like, oh, well, Max can talk, Max does schoolwork, Max XYZ, insert stereotype there. But yes, I'm still autistic. And so that diagnosis really opened up a lot of emotions. This was kind of at the peak of what I call the autism myth wars, where a lot of organizations, who I shall not mention by name, were promoting ads claiming to have a child being autistic is the same as a child being kidnapped, or that at least empty shell, or it's better to not be autistic. And as a middle schooler, already with OCD and depression, it obviously was a lot. Wow, this is me. I must be broken. And so that went on for a couple of years. And eventually I started talking to other autistic people. And I realized that there's a big disconnect between what autistic people are saying and what like the rest of the world is hearing. And so I am like to present on panels, and I'm happy to be here. Sorry, that was a lot.
No, that was absolutely perfect. Thank you for joining, Max. And I love two things that you just said that are really like takeaways for me. And the first is that how kind of tone deaf it would have been for us to have a discussion today on OCD and ASD and not have you or somebody with a lived experience on the panel, right? The first important thing that I'm hearing you say is like, yeah, like you can have the clinical background, but if you don't have the lived experience, it's really hard to relate and to fully understand. And so it's really important when we're providing education, when we're providing treatment resources for individuals with ASD and OCD or ASD in general, right? That we're really thinking about those personal lived experiences and making sure we're including them in the discussions and in the outcomes that we then go and pitch, right, to clinicians and to others. And then the second piece that I really want to talk a little bit about is the misinformation and the misunderstanding that the community often has. I love that section of your bio that talked about how you really focus a lot of your time on like debunking the myths of ASD. And for those of you that follow some of the advocacy work that I do, right, I'm really big on like debunking the myths of OCD. And so it's perfectly fit for us to spend some time today doing that with ASD. So I would love to just start there. I would love to start with both Dr. Sachs and Max. Like I would like to hear both of your perspective of some of the common myths and misconceptions that actually increase stigma for individuals with ASD. So Max, do you want to start?
Sure. I think one of the biggest ones that impacts me most often is that when people find out that I'm autistic, either I disclose it to them or they've asked somebody, immediately, 9 times out of 10 or however often, overwhelmingly they will immediately talk down to me. They'll adjust their facial expression, which like, I don't understand anyway, but like they'll just look really sad, like, oh, I'm so sorry. And then they'll talk to me like I don't understand when 2 seconds before we were having a conversation about whatever it may be. And so I think definitely, I think the better term for it is presuming competence. And while some autistic people do have intellectual disabilities, and some autistic people may have difficulties in expressing what they know, that doesn't mean they don't know things. And so I feel like a lot of times people assume, both on a personal level and I see it with my autistic peers, people assume that, oh, you can't know this, or oh, you just don't understand it. So I think that's really important. Another thing I want to mention is that a lot of people, this is sort of calmed down in the past few years, have maintained the belief that autism is a bad thing, and that like the whole, I love my child, but I hate their autism.
Hmm.
And like, I'm not denying that autism has a lot of challenges. It does, whether we want to call that because of living in autistic and neurotypical world, a world designed for people not like me, or we want to come directly to the neurology itself. It is difficult. There are difficult parts, but I can't untangle my autism from me. Like, I think I forget the advocate who said it, but when I go to the airport, I don't check my autism in a suitcase. It is with me all the time, and I personally, I like being autistic. I enjoy the differences that some people see as disabilities. I enjoy that quite a lot. I like my passion is really, really important to me, and my special interest, like writing and psychology. I mean, that's what's allowed me to present on these panels, is because I've spent most of my, since I was like 8 or 9, reading about psychology and devouring every source I could and listening to interviews and everything else. And so I think the most thing I want to say is that autism isn't necessarily bad, and that autistic people are okay as they are. Caveat, I know that autism does come with challenges. I know I said that, but whenever I say autism is by itself not bad, I feel like people are instantly, well, my kid can't do this or my kid can't do that. And so, yes, a lot of the conditions that come along with autism, like epilepsy and GI issues and insomnia and anxiety and depression, those all are real difficulties, but they are not autism itself. So that's a long-winded way of saying what I want to say.
No, it's perfect. And I actually want to ask a specific question that we'll get to in a second that's specifically related to what you just mentioned, Max. But Dr. Sachs, anything on your end that you want to make sure the audience knows about some of the myths or misconceptions, especially when working with individuals that you might see clinicians or other people tend to have?
Yeah. So I think for me, there are 3, and I will try to be brief. So one is this idea of high functioning or low functioning. I think we should just sort of like throw those terms out the door, because what defines functioning? Is it like intellectual ability? Is it verbal ability? I think what Max is saying is people like know a lot and people understand a lot, even if they're not sort of responding in the more typical ways that we're used to, and that shouldn't define sort of functioning. I think it's just more we should be thinking about what is a successful, meaningful life for this person in front of me, for my patients, and how do I help them to that? Like, what are the barriers getting in the way? That's what I want to address in treatment versus high functioning or low functioning. I think also Max was sort of talking about this, is this idea of like pathologizing every little thing about autism, that, you know, I have specialized interests too. Like I know lot about certain topics and have devoured a lot of books about certain topics. Nobody ever says is like, oh, like, Rebecca, don't you think like maybe you should stop talking about this thing and learn a little bit more about something else? Nobody pathologizes my specialized interests. Like, why? And I think sometimes there's this inclination to do that, as opposed to just like sort of labeling, like on face value, this is just what this person, you know, how they think or what they do. And it doesn't need to be like changed in any way. Or like stimming even doesn't necessarily have to be pathologized. That's what they do. Like when they're excited, I sort of do that too when I get excited. And then the last myth that I would say is this idea that autistic people don't experience empathy. I actually think from the research we know is that there's a subset of individuals who are actually like empaths, who experience empathy like overwhelmingly, and sometimes they may experience shutdown, or sometimes they may respond in a certain way. I think the more important thing is that we've actually seen as autistic individuals of all abilities and all thinking styles do experience empathy. It may just be that they respond when they're thinking about, oh, I know that person's sad, or I know that person's thinking negatively. Their ability to maybe make sense of it in a typical way or respond to it in a typical way is a little different. And the best example that I can give is there are moments when a patient is disclosing something that's like either traumatic or very vulnerable or a breakthrough, and I sit there with overwhelming emotion and empathy, and I say to my patient is, oh, I'm having this urge to hug you, but I know you probably don't want that. And they go, you're right. Please don't. And so it's this recognition of like my sort of neurotypical empathic response might look very, very different than a typical autistic empathic response. And neither way is right or wrong. They're just different. And so sort of understanding that, I think those are the three big myths that I think might affect clinicians the most.
Yeah, no, those are great and very helpful. So one of the things I was thinking of, and I see this clinically, and I would love to hear, Max, your perspective first, and then Dr. Saxter's as well, is what is it like to receive an ASD diagnosis? And, so I've seen time after time when clinicians are wondering if one of their patients is living with ASD, but they avoid discussing it with the patient or kind of talking about the diagnosis for whatever reason it might be, is like, oh, they're here to do OCD work, so we'll just kind of focus on OCD, but like, I think this could be going on. And so it's interesting because sometimes it will impact the way the clinicians are thinking about treatment, but they're not necessarily talking about it with the patient. And I don't know why. I wonder that. And I think that I also think sometimes there's been situations where maybe I've talked about it with parents of a patient, and the parents will say something like, well, like, let's not talk to them about this. Let's just kind of keep it amongst each other and think about it as a potential. And I'm just wondering for you, what was it like to receive the diagnosis? And what have you heard from the ASD community, Max, as far as like, is that empowering? Is that something we should be talking about from the beginning? And I know one of the comments that someone else made is that, that that their clinicians don't have experience, but they think they may have ASD and that they were misdiagnosed with ADHD as a child, and that they've been doing all this research on their own to try to understand if that's the case.
So I think that's a really good question, and I've been trying to follow along. I first want to say that diagnosis as an adult with autism is a privilege in the United States. I can't speak for other countries, but I know that our healthcare system has problems, and that it's a lot of work and often very expensive and draining to receive an autism diagnosis if you're even able to find a professional who says, like Dr. Sachs was saying, oh, well, they're masking, so they seem normal. I think having taken time to peel away that is very important, and not a lot of people have. So I do think self-diagnosis is valid. I know in the OCD community, a lot of people say, oh, I'm so OCD, and we hear that, and I'm like, oh, don't say that. But I feel like no one really uses autism like that. I think partly because autism is so stigmatized, and no one really says, oh my God, I'm so autistic. Like, if someone has done research, as autistic people are good at research and are like, hey, I think this is me, that's a big step. So I do think self-diagnosis should be respected. Moving on, I do think that it really depends on what that person has heard about autism and what their underlying beliefs are. So when I was diagnosed as a child, I was kind of a nerd. I was a nerd. I didn't go on the internet much. I didn't watch TV. I didn't really listen to music. We didn't have cable, so it's PBS Kids or nothing. And so the only thing I knew was from what my parents told me and what teachers told me. I had friends, but not really, and what I was reading in books. And so I feel like as a child, if you're worried that a client who's a child might be autistic, I do think that before telling the child, and I do think people should be told if they are autistic, that the parents know, or caregivers know how to respond and create a affirming environment. Like when I was diagnosed, and I want to stop and say my parents are absolutely wonderful now. It was a learning curve for everybody. I don't know if they're watching this right now. But I heard a lot of autism is bad, autism is this, autism is this, you're never going to do this, your teacher say you won't do this, you can't do that. And I'm like, oh my God, like this is the worst thing ever. And when my diagnosis was reaffirmed at 18, because I had to get it transferred over to get accommodations in college, I knew I was autistic, but getting that diagnosis and hearing the neuropsychologist go over all my evaluation reports, I felt horrible. I'm like, oh my God. So the way the neuropsychologist framed it, it was like, this is where you should be, and this is where you are. This is what normal people do. This is where you are. This is what other people do, and this is what you do. And I'm like, okay, like I think framing the conversation around, yeah, you're autistic and it does have challenges, but it's not a death sentence. Like, you'll be okay. And so I feel like that is very important, of trying to say, yes, you're autistic. Here's other autistic people. Obviously, in some communities, it's not feasible, especially during COVID, to meet in person. But there are Facebook groups. Yes. So I think that's what I want to say.
Love it. Absolutely. I think that's it's so helpful, and it's so important to know, right? And for us to think about what language are we using, whether we're clinicians, whether we're family members, whether we're a friend of somebody with a ASD diagnosis, are we using language that's empowering? And that, yes, while it may have challenges, we're not honing on the challenges or the differences. Instead, we're honing in on the amazing qualities, right? And the strengths that having this diagnosis might bring, and or what you can make of it moving forward, and how you can kind of play this to your strengths.
I do think, sorry to cut you off, I do think that we should talk about the challenges and say your autism is making this is the reason you're struggling with this. If I had known I was autistic, I would have thought, well, I'm just really dumb. Like, I can't do this. I must not be trying hard enough. I must not be good enough. Like,
so there was some validation too in a diagnosis, and understanding the unique challenges that the diagnosis has, so that you could label it appropriately, right? Of like, this isn't me, this is my diagnosis, and here's how I can address it.
Sort of. I think maybe because I have this diagnosis, yeah, it took me a while to process. My audio is slow. But yeah, I do think that, and also connecting them with resources and realizing that just because someone can't do this doesn't mean they can't do that. I mean, I talk all the time, I don't know how to tie my shoes. I'm 23 years old and I don't know how to do that. I can't read an analog clock. My handwriting is garbage. I'm stuck at making eye contact, but I've also done X, Y, and Z things. A lot of times in autism, a lot of times people say, oh, well, if the autistic person can't do this, then they won't be able to do this. Mm. And that's not necessarily true. Like, the precursor to going and speaking in which is not being able to tie my shoes. Like, that doesn't equivalent. That's not equal. Sorry.
Yeah, 100%. Dr. Sachs, what do you think? What are some important things for clinicians when we're noticing some of the diagnostic criteria, being met for ASD, and we're potentially thinking about it as one of kind of, as we conceptualize and understand our patients, how do we go about it? What do you do, and what do you recommend when, as a clinician, you start to see the inklings that make you think, okay, they may have a comorbid condition?
Yeah. So I think Max hit on a lot of my answers. So I'll just maybe in addition to that. In general, I like to share with my patients what I'm thinking. I would say 99% of the time, I feel like if I went to a doctor and they suspected something was going on with me, I would never want them to withhold that from me. Like, I'm entitled to know like what people are assessing about my mental or physical health, and that my patients deserve the same. So I think it might be more is, how do I go about, like, what does the process look like? Some things in mind are, yes, what is the family system sort of like, and how is the family system going to be supportive or not supportive? And I might need to address that if I think the family system is not going to be supportive. Or well-informed. I also do look at age. I mean, there's some emerging research, there's not a lot, but it also sort of syncs up with my clinical experience that I think young children and young adults and adults respond really, really positively with a diagnosis and this adolescent phase. I would say especially the older adolescents. So I think if you can catch them preteen and early teen, it's usually a positive response, but it sort of makes sense during this age when identity and figuring out identity is already rough, is when I might not necessarily use the label per se. I think having a very strength-based conversation, so not just saying like, here's what might be difficult for you and here's why, but also here's what we really know about what's cool about your brain, or here's what we know about where your strengths are and your relative strengths, but also why you might feel frustrated in certain situations. And then I think the last thing, which Max sort of hit upon, is this real idea of community. That there's this wonderful community of other autistic people out there, and to really try to connect. So there are some really good support groups out there, even some virtual ones. There are some really great books out there. There's a very new book called We're Not Broken by Eric Garcia that I would recommend, like, and so giving people memoirs or books or things like that also to dive in and get a really positive sort of lens on the autistic community too, when you're starting to share this information.
Perfect. Love that. That's super helpful. And I wrote some notes down, so we'll cover some of this at the end as well. But I want to jump into kind of a couple specific questions that I have as we're also, for those of you submitting questions, I'm trying to integrate those questions into the topics that we've discussed. So Delta, I know you've been talking a lot about your personal experience, and we've tried to address that in different ways. So I'm hoping that we have. I know one person in specifically asked about the correlation of OCD, anxiety, and ASD. And we do know that there is high comorbidity, right? That we do see these disorders often are co-diagnosed or diagnosed together. So we do know that that's the case. So then the next question that's important for us to jump into is treatment. And so I want us to talk about two things. I want us to talk about what are some of the, we don't need to go into specifics, but what are some of the general treatments used for ASD? And then what or how does treatment, if there is, and then how does treatment differ for somebody, in particular, someone's OCD symptoms, if they have a comorbid ASD diagnosis, right? So is it just like typical ERP, like the traditional route, or do we augment it a little bit different if somebody has an ASD diagnosis? So Dr. Sachs, maybe we'll have you go first.
Sure. So two questions that I think you asked. So one is like, what would you do with autism? And again, I don't know if you necessarily treat autism. I think what you're often treating is the co-occurring mental health condition that autistic people are probably much more vulnerable to developing for a variety of different reasons. And when you actually talk to autistic people, like trauma is actually one of those up there, which I know is like a whole nother piece, but I want to throw that out there for clinicians to hear. I think again, you can, and it depends on where the patient is at. If sort of those core thinking differences are having some kind of discord from the person leading a valued life, that's where I think you can just still rely on CBT, including acceptance and commitment therapy, maybe just delivering it a little differently to address emotional regulation, to address sort of maybe like more rigid or less flexible ways of living. But yeah, I don't know if the autism needs to be treated. In terms of OCD and ERP, yeah, at the end of the day, you're still doing ERP. At the end of the day, you're having people learn about OCD, be able to recognize OCD, catch themselves, understand a thought is just a thought, a feeling is just a feeling, right? An urge is just an urge, and then really have people doing opposite action. How people may hit all those steps may look a little differently. And one of the biggest ones that I often say is pacing. Like I probably do a lot more low and slow with my autistic patients versus my non-autistic patients. So I think just in terms of framing your treatment plan or framing your expectation about either frequency or how long you're going to do until somebody has done their first exposure or doing their first self, independent exposure out of session, where on the hierarchy you're going to be. And sometimes I don't even do hierarchies really with my autistic patients. I find them less helpful. I would say are the two biggest things about how I do ERP differently.
Okay, great. Yeah, that's very helpful. And I guess so one of my questions clinically that I've seen is when I've had patients with ASD and OCD, in particular, when we're talking about contamination OCD, there's been times where with somebody without an ASD diagnosis, sometimes I see more very clear of like, hey, here's my OCD symptoms. I want to get rid of them. Like, help me fix it. Where I can remember a couple cases where I've worked with patients with ASD and OCD, and there was less desire to fully get rid of the compulsions and more desire to just kind of make them more functional, right? So, hey, I don't necessarily want to give up this whole routine, but I do want to make it faster because it's impacting my day and it's taking a lot of time. Do you see that at times, Dr. Sachs? And when you do, how do you, because treatment does look a little bit different, right? If it's not so clearly ego dystonic, when it's just OCD.
Yeah, so that's where I would say is, so I don't know if necessarily having rituals is OCD. Sometimes we call, like, one of the DSM-5 calls it non-functional routines, but for a lot of autistic patients, they actually are functional routines. They just look to the like outsider that they're non-functional. And I think that may be sort of what you're saying, especially when something feels a little bit more egosyntonic, having structure, doing things a certain way, maybe eating the same dinner every night. You also have to think about executive functioning and how much energy and effort it takes sometimes to plan, to prioritize, to switch. I think a lot of us neurotypicals have experienced that in the pandemic, how exhausting that is. So if a lot of these routines can take those exhausting things off a person's plate, it gives an individual a lot more bandwidth then to spend on maybe going into a social situation that's already going to feel challenging, going into a sensory overwhelming situation that's already going to feel challenging. I think part of it is there are so many things in a neurotypical world that really sort of poke at buttons and challenge an autistic individual. We often don't appreciate how draining just going through an average day can be for an autistic individual. And so like some of these sort of routines may actually be sort of like life hacks that are helping them get through the day. I think it is when you're saying, does it impact functioning negatively? Is it really, really distressing, that ego dystonic element? Yeah, that's where I feel like we're definitely more in OCD world, and we want to make sure we're addressing it.
100%. Yeah. Max, I would love to hear from you because I saw you shaking your head at times. And so would love to hear a little bit about what you have found in practice, right? So in treatment, what do you think maybe are some of the things that worked best for you when someone was treating your OCD? And you are muted, sorry.
Thank you. My cat was being weird.
No problem. We do love animals on here. So if you decide you want to put your cat in the frame, we'd love to see him or her.
He's ignoring me right now. Attention. So showing a fit. So I do think, so I started ERP treatment when I was 15. Even though I was diagnosed with OCD at 8 for various reasons, didn't get into ERP treatment until 15. And so my therapist, who's still my therapist now, actually, it helped if she were to like remind me that I was thinking in black and white terms. Like when I started doing exposures and I noticed they were working and I could like feel my OCD loosening its grip, and I'm like, this is awesome. I would do exposures. Before that, she would be like, my obsession was, what if I hurt myself even though I don't want to? I forget the ego dystonic thing. I'm not good at terminology, but I don't want to, but what if I do? And that was obviously really distressing. And so my therapist had me say, well, you might. And what I took that to mean is I will or I won't. And so I got really good at saying, I will hurt myself. I will hurt myself. And I'm like, but I don't want to. And I thought that was exposure. And so it really helped. She had to point out, no, you're trying to get the uncertainty. When I thought, oh, well, if I'm afraid I will do it, then I'll say I won't do it. And so her just really pointing out the subtleties and taking it slower than I think other people who are not autistic would have gone through ERP treatment. Because a lot of the time we just took one exposure a session and was like, okay, we're going to break it down. And she would have very clear guidelines. I think that helps a lot, is knowing what was expected. Like that takes a lot of anxiety and stress away too, because the day-to-day situation that I'm unfamiliar with, that's terrifying. I mean, most of the time I practice scripts or like lay out what I'll say ahead of time. Like, oh, if I go to Target, here's what I do. And there's like a routine for each of them. So I think taking it slower and emphasizing what is expected is really important. Obviously, I'm not a clinician. I can't speak with expertise on that. And the other thing that Dr. Sachs mentioned was treating the comorbidities. So I also have sensory processing disorder, which I've had all my life, but didn't find out about it until about a year ago. And I've since started sensory integration therapy, which has been so helpful. And that has taken a lot of my everyday anxiety away. I was actually diagnosed with generalized anxiety disorder at the same time my OCD diagnosis. And I always felt like, I mean, I read the DSM, I'm that kind of nerd. But I'm like, I don't really feel like this. And I talked to my friends with GAD, and they're like, yeah, I don't relate to that. Once I started doing sensory integration stuff, I noticed my generalized anxiety just disappear.
Wow.
And so I feel like that was maybe a misdiagnosis. And my occupational therapist explained it as when your body is not getting its sensory needs met, it goes into fight or fight mode. And if you're in fight or flight mode constantly for 24/7 years on end, you're going to be anxious. You're going to be wired with anxiety. And so now, as part of my therapy, I do a lot of deep pressure. I have a weighted blanket. I made a swing in my basement that gives me deep pressure and I can swing. I have a mini trampoline and I go and take these breaks and feel the anxiety melt away, which also helps with OCD. And I'm more willing to do OCD exposures if my baseline anxiety is already lower.
Right. Absolutely. As are most people. And that, I mean, I think that's really important for us to think about. And two of the takeaways that I heard both of you saying is one, actually earlier, Dr. Sachs, you said like, you don't do as much hierarchy. And Max, I heard you saying like, sometimes it was just one exposure at a time, you know, and I'm thinking about like clinics like ours here where we do, you know, residential and intensive treatment here in Houston at McLean. A lot of what we do is coming up with a list of multiple exposures, but I'm wondering as we're talking for someone with ASD, that could be really overwhelming, right? To have all of these versus like, let's break it down to really one at a time. The second piece, Max, that you mentioned that I want everybody to hear me saying is that important piece of uncertainty and really making sure that patients understand the concept of the exposure and exactly how to do it is not just critical for patients with ASD. Maybe it even needs to be heightened, but for anyone with OCD. And I actually see this happening all the time where patients will say, well, I'm doing ERP, right? Because I'm doing the exposure and I'm not engaging in the response prevention. But oftentimes they're like white knuckling it and they're doing this exposure and they're like preventing themselves from not engaging in the ritual, but they're not actually leaning into uncertainty. They're not actually leaning into that core fear. And so it's really important what I hear us saying today that for patients with ASD and with any other patients as well, make sure you slow down. You spend more time making sure that the exposures, you don't just think, oh yeah, they understand what I'm saying, that we really understand what they look like in practice, because that subtle difference that you talked about, Max, of I will hurt myself or I won't, compared to maybe not, very different in how the outcome is going to be. But also it makes sense of why, like, well, how was I supposed to know that it was that different if I practice it?
And if I could piggyback, I think that's why linguistically I talk a lot more about opposite action, like, because conceptually, I think that helps. What's my emotion? What is my emotion trying to boss me around to do? Will that really serve me in the long run? Probably not. So let's actually do the opposite. And sometimes it might not be like an OCD exposure. Sometimes it might just be more being like a bit more flexible or doing something, even if I like don't want to, or I find it boring, or I don't fully get it, but like I'm still going to just try it at the very least. And that might actually be the exposure or the opposite action that we're sort of leaning into, the discomfort.
Awesome. This is so helpful. And I will say, I know we're running out of time, so we're going to have to wrap up, but this has been very eye-opening for me and very important. And what I want to just say thank you to both Max and Dr. Sachs, but what I want you to hear me saying is not like, thank you, goodbye, but instead like, thank you until next time, because I 100% want us to do this again, because I think we just scratched the surface, right? All we really got to today is the diagnosis, the misconceptions, and kind of the first step to treatment, but we didn't get to talk as much in detail. So I would love to have you both back so that we can continue this conversation, because I think it's more than helpful and critical for our audience. A couple things that were asked. So one is, Max, a couple people have said, what support groups do you recommend, and how can those with OCD and ASD get more connected with the ASD audience? So I would love for you to share that and any final thoughts that you have.
Sure. So as far as unfortunately, there aren't a lot of specific OCD ASD support groups that follow exposure ERP guidelines. I will say some of the general autistic groups that are, a lot of people who are autistic have OCD. And so as more ERP knowledge people are getting that, it will filter down. Because I saw someone ask about the queer community as well. Top of my head, Autistic Women and Non-Binary Network. I don't think that's the right name. That is the right name, because they changed it to include non-binary. ASAN, Autistic Self-Advocacy Network. There's a bunch more like I'm blanking on. But there are a lot of autistic people who are often, because people who are autistic are actually, I think, I'm going to misquote this, 6 times more likely to be transgender or gender nonconforming, which is a total other discussion that is super, super interesting. But what I'm saying is that the communities do exist. You might have to do some poking around and trial and error, but they do exist.
And it's important to know, right? I want to remind everyone that even if there's 1 or 2 support groups you find, if they're not the right fit for you, keep looking, right? Keep advocating to find the group and the network that works for you, because it's there. Sometimes we just have to advocate for it, whether it's OCD, OCD and ASD, OCD and, LGBTQ, etc. Right. So just keep looking. Dr. Sachs, final. Oh, sorry. What was that, Max?
No, I just wanted to real quickly say, especially on Facebook groups, like if you think everybody's on Facebook, that's a lot of people. And anyone can find a group, and not everyone will be at the same stage or similar stages of ready to accept help or stages of treatment. And so I do think some of the larger groups are good for certain people in certain stages, but it's okay to find different groups and do some more digging as you progress and go through different life stages.
Absolutely. Dr. Sachs, final thoughts or questions or anything you want to share with the community as we wrap up?
No, because I could talk forever. I would just, no, I would say, like, look, I realized reflecting, being in front of my computer and doing teletherapy and like sort of isolated for so long, the majority of my pandemic, I've been hanging out with autistic individuals more than neurotypicals. And it's actually made for a great pandemic experience. So, and like, it hit me a couple of times that was my experience. I was like, these are the best pandemic bedfellows a therapist could ever want. So I guess that would be my final word, in some ways. Yeah.
And my final words, which they always are, is to remind everybody that help and hope are always available. And I think today what we're trying to share is that it doesn't have to be OCD treatment only exists for people with just OCD, right? That's very rare. There's very rare that somebody has just an OCD diagnosis. So we should be thinking about and talking about comorbidities. And in particular today, the point of today's discussion is to bring light and discussion to the comorbidity that exists of ASD and OCD, and to really talk about how treatment works and what treatment looks like. It's important that we continue to do our work to destigmatize and to better be inclusive of all diagnoses when we're talking about a comorbid OCD diagnosis as well. So remember, help and hope exist, and work to find the community that's there for you. And make sure you check out the IOCDF conference, because this year, both Max and Dr. Sachs are presenting together. So I certainly recommend that you check it out. There will be many other talks on the comorbidity of ASD and OCD at the conference. Thank you all for joining. Thank you. A huge thank you to Dr. Sachs and Max for sharing your personal experience. I know that it's not always easy to do, but I can promise you it is helpful for everybody watching. So thank you both.